and then I'll tell if you guys have to keep your camera on and everything. So make sure you keep your mic. Isrrt monthly webinar series. My name is Steve Lacey and I am the Isrrt Director of Education. Today is actually a very special webinar for a number of reasons for the Isrrt. It's the first webinar that we're going to be running and hosting through our Zoom platform as we move away from our usual Facebook Live event. Today's webinar is a special recognition of the WHO World Patient Safety Day campaign. And as we recognise World Patient Safety Day, we need to think about the role that we play as radiographers and radiological technologists in improving the diagnosis for patient safety. And so today I'm actually joined by two very special and passionate individuals who are both from the UK and from Australia, and we'll be discussing the role that we play in communicating abnormal findings on images in a timely manner. So let me just introduce our guests. Our first guest is Jonathan Hewis. Jonathan originally was from the UK, and his areas of clinical expertise include extensive experience with major trauma imaging, neurointerventional radiology, specialising in MRI, performing and reporting gastrointestinal studies, and planar image interpretation. Jonathan entered academia in 2005 and is currently employed as a senior lecturer in medical imaging at Charles Sturt University. Jonathan's main research interests include lived experience, person-centered care, image interpretation, and advanced practice. He is an associate editor with the Journal of Medical Imaging and Radiation Science. He's a fellow of the Higher Education Academy in the UK, and he's a member of the Isrrt New South Wales Branch and Research Committee and the chair of the Isrrt Advanced Practice Reference Group. James is the Associate Professor in Diagnostic Radiography at the Faculty of Health Sciences in the University of Bradford in the United Kingdom. He qualified as a diagnostic radiographer from the University of Leeds in 2002, and he began his postgraduate education in radiographic reporting and image interpretation in 2004, and completed his Master of Science in 2011, followed by a PG Cert in musculoskeletal ultrasound in 2012. His clinical roles in both primary and secondary care included the reporting of radiographic examinations of the MSK system, chest and abdomen, as well as performing MSK ultrasound up until 2020. And since moving into higher education in 2012, his main role has been leading anatomy and image interpretation education for a range of health professionals at both undergraduate and postgraduate level, including radiographers, physician associates, advanced nurse practitioners, and doctors. Between 2017 and 2019, he was seconded as a clinical educator to help develop and manage the UK's first clinical academy for radiographer reporting. In 2023, he moved into his current position at the University of Bradford, where he leads the postgraduate radiographic reporting modules. James's main research and scholarly interests are in the development of image interpretation education, with a particular focus on preliminary image evaluation or commenting and advanced practice. He has presented his work at both international and national conferences and has authored 2 books on anatomy and radiographic image interpretation of the skeletal system, the most recent being published last year and entitled Image Interpretation, Bones, Joints and Fractures. So today, Jonathan and James are talking on the topic of See It, Say It, communicating abnormal X-ray findings for patient safety. And if you have any questions throughout the presentation, please make sure you put the questions in the chat function on the Zoom. Thank you and enjoy the presentation.
Good morning, good afternoon, good evening, and potentially good night to people looking at this across the world. My name is Jonathan Lewis. I'm from Charles Sturt University here in Australia, and I'm joined by Associate Professor James Arcus from the UK, from the University of Bradford. This evening, for me, my time, we're going to be exploring See It, Say It, communicating abnormal X-ray findings for patient safety. Today's presentation will be structured the following way for you. So we'll provide a background to radiographer commenting, which has various names, one being PI, different levels of image interpretation, to include just briefly looking at advanced practice for radiographers, the fundamental principles of image interpretation, which you will have many of these skill set already as a qualified radiographer, but also if you're a student radiographer listening as well. How we might communicate those findings, whether that's in an oral form or perhaps more formally in a written setting. And then if you want to develop your image interpretation skills more for communicating abnormal findings, how you might develop those.
Okay, so we're going to start by just sort of thinking about where this this idea of the comment fits in terms of different levels of image interpretation. So when we talk about image interpretation as a concept, we could potentially consider it in a number of different ways, from the very basis of we produce an image, a radiological image, and we assess it in terms of its technical adequacy, its technical quality, to ensure it's appropriate for a diagnosis. And that's kind of probably seen as the first stage of image interpretation. And certainly historically that has traditionally been the role of the radiographer, the radiological technologist. But over the decades, certainly in the UK, in particular, we've progressed from that being the role of the radiographer to actually where radiographers were actually supporting clinicians by providing an informal or a verbal comment. So when they were seeing something, they were actually communicating that to the clinicians. And that kind of then leads to the next level of image interpretation, whereby if we actually identify an abnormality, we want to be able to flag that to the clinicians. And that's where the term radiographer flagging systems has come from. And most commonly, this is known as the red dot. The name red dot comes from where, when using radiographic film, we actually put a little red sticker on the image to flag to the clinician that the radiographer had actually spotted something. And that's then led to kind of the next stage, which is what we, depending on where you are within the world, a number of different terms to define what we commonly call the comment. The comment is where we actually writing and actually recording an interpretation, an informal interpretation, which will go along with the image. So it's commonly called a comment, commonly called a preliminary clinical evaluation, or a PCE, or a preliminary image evaluation, or a PI. And then kind of then the highest level of image interpretation is what we would necessarily call the clinical report or the formal report. So this is what historically and traditionally is performed by the radiologists, and this performs the formal interpretation, the documented interpretation that will go into a patient's notes. And this is, traditionally the domain of the radiologist. We also then potentially have to consider how images are also interpreted, not necessarily by and within the radiology department, but also within the wider clinical departments. And the term clinical evaluation might be used in certain circumstances to consider how non-radiology professionals might actually interpret images as part of the patient's notes. So to give the comment, the PI, the PCE, it essentially means the same thing, a definition. We've taken this from the College of Radiographers, which is whereby the radiographer will assess imaging appearances. They will make a judgment upon what they see and understand, make a decision on that, and communicate it in a written form back to the referrer. So that's essentially what we mean by comment, PI, PCE. So we wanted to just give you a little bit of a perspective in terms of why it's important from kind of a regulatory point of view, both from the UK and the Australian perspective. So certainly within the UK, the HCPC, the Health and Care Professions Council, who are our regulatory body for radiographers in the United Kingdom, they certainly define that radiographers should have the ability to be able to interpret images and just diagnose urgent and unexpected findings and be able to communicate them. The College of Radiographers, so our professional body in the UK, actually goes that bit further and say that actually this should be a competence that all radiographers should have upon graduation, upon qualification, and that actually is something that we should be doing as part of our standard practice.
To touch on what James was saying there and give you a bit of an Australian perspective, we have a similar, setting for commenting here in Australia. So the regulator, MRPBA, the Medical Radiation Practice Board of Australia, very clearly actually outlines in the capability framework that radiographers need to be able to differentiate between normal and abnormal. particularly around this idea that we need to identify urgent and unexpected findings, and that needs to be communicated. It does suggest that perhaps may be initially to the radiologist. However, if the radiologist is not available, or for more timely, I guess, intervention management of a patient, that will be to the referrer or to another appropriate healthcare professional. It also makes it very clear that this also needs to actually be documented and therefore captured, so that it is actually communicated and there is evidence for that going forwards. These are based on slightly wider standards, which we'll probably don't need to look for this particular forum, but actually looks at the deteriorating patient in general, so that a radiographer in the Australian setting actually has a responsibility to, I guess, see something, say something, or see it, say it, not just related from an imaging perspective, but also of a deteriorating mental health, but also physiological deterioration as well. So it's quite strongly written into our regulatory requirements. And then the professional body, Isrrt, also has formal training in this space. And that's where the PI name comes from, for preliminary image evaluation. There's some growing research that's coming out of this space, but also interesting kind of impact or lack of impact, unfortunately, that potentially has been published. And there's a great paper which published relatively recently, which is capturing some of the opportunity to communicate, or radiographers would have to communicate, for 3 very specific patients from the coroner's perspective in an Australian setting. And this was published this year, has been shared in professional forums prior to this. These 3 examples are misplaced NG tube, missed pneumonia, and then a button battery, which was being swallowed, I think from memory, for a paediatric, all which resulted in death. Hence, the coroner had gone back and looked through those cases and had identified very clearly that actually the radiographer had an opportunity in each of these particular cases to communicate abnormal findings that were urgent and significant, and therefore could have potentially changed the outcome for those particular patients. So it's probably quite harrowing reading to some extent, but I think really flags the impact, if we're looking at a sort of patient safety, that radiographers potentially can have as frontline staff, which are working obviously both in the day but also out of hours, and communicate and have a lot of the knowledge base and skills in this space. I think also to put a kind of context, I think, from expectation probably for maybe our patients and the general public, is that if we were walking, I guess, say you're in a hospital setting or a clinic setting, and your patient collapsed in front of you, you would be expected, I would expect myself, my colleagues, my students, and other professionals to actually be involved if the person had, a cardiac arrest or something there, and actually get involved. And obviously that will be documented and formalized. So I think perhaps it's a little bit less of why we should be doing these things, but it's actually why not. So just because it's on an image, I think, we have the same obligation and duty of care that if we see something urgent and significant, that we should definitely be communicating this to other healthcare professionals. So the process of image interpretation is well, this shows a little bit linear. It doesn't necessarily as linear as this kind of process, but it goes through stages. And actually, as part of our education kind of process, we spend a lot of time, first of all, looking at technical kind of quality adequacy in those kind of components. So there's an element of detection that goes in that kind of process. And obviously, we're doing that with some of, obviously, the performing of that kind of process. But actually, obviously, the ability to detect and see an abnormality. We have to actually then be able to actually interpret and have the skills in that space to interpret, which partly relies on knowledge of anatomy, for example, but also things like around pathology and those sort of things as well. There's an analysis that kind of goes with that, and actually perhaps looking at the context for the particular patient, the clinical referral, the clinical question, how they're presenting, maybe the age of the patient and things like that as well. So actually we come to a conclusion or findings based on some analysis and process and consideration of that process. And then the fact that we convey or communicate our findings appropriately where needed in particular. And I think from the Australian perspective, it's very clear when there's significant, urgent or unexpected findings that have, I guess, management considerations, it's expected to communicate those and document that communication as well. So this is a Venn diagram which one of our colleagues, Voyen, actually loves, so shout out to Voyen, just to show you really that actually the contributors or factors to image interpretation are quite complex. There's many factors that we need to, I guess, master. But the prerequisites actually on this far right circle, perhaps you can take home some comfort that if you're actually learning image interpretation or a novice in this space, knowledge of anatomy and image techniques are kind of the fundamental kind of requisites to actually image interpretation.
Yeah, so to kind of follow on from that, often you hear people say, well, I haven't got the skills to actually interpret that image. But actually, if you think about the skills that we do have as radiographers and radiological technologists, we have a lot of things that actually are key to understanding what we see, not just seeing things, but actually understanding why we see what we see. So, for example, that in terms of image interpretation, we need to understand what is in the image, i.e., how was the image produced? How did the interactions in the body, the different degrees of attenuation lead to the different shades of grey that we actually ultimately see on the images? We also need to understand what's in the patient. So we tend to have a very good appreciation of anatomy and physiology, and a good understanding of anatomy and physiology is absolutely core to being able to interpret images accurately, and we'll talk a little bit more about that later on. We need to obviously understand what was conducted, so what techniques we used, what position was used for the patient. So by understanding the patient position and how that image was actually achieved helps us to understand in what we see. And we also need to be aware of what the limitations are of an examination. So if we're taking a radiograph, for example, we need to understand what tissues can we see, what we can't we see, what are the effects of artifact, what are the effects of superimposition. So is what I see real, or is it caused by an overlying soft tissue, for example? So all of these things are absolutely core to all of our training. So we've already got these in our armament before we even start to think about more advanced techniques or processes in image interpretation. So, for example, we've got two images here, and I'm posing the question, which one is the effusion? Okay, so the image on the left is taken with a patient erect. The image on the right is taken with a patient supine. So we need to think about, okay, well, how was that patient positioned? What is the effect on gravity on the fluid which forms the effusion? When the patient is erect, gravity pulls the fluid towards the bottom, towards the costophrenic angle, so the fluid will appear as this solid density in the left lower zone. Whereas if we lay the patient supine, then that fluid will spread out across the entire hemithorax and dissipate throughout the entire pleural space. So therefore, which is the answer? Well, they both are. But our understanding of the effect that the positioning has on the patient is key to understanding what we actually see.
So what might we look at first? And obviously we could jump in and perhaps looking blindly at these things, but perhaps we need to have a little bit more of an approach to how we might actually look at image interpretation. And technical adequacy is the starting point. So we will talk about in a moment actually certain strategies we might use for image interpretation, but also strategies start off with adequacy. And as a radiographer, a radiological technologist, then obviously that's a pretty core kind of part of our training, and students spend a long time trying to discover and identify what is adequate. And partly obviously that comes down to the clinical question and obviously addressing and enabling a diagnosis. And so that is probably one of the kind of critical kind of components in that space. And we have to make decisions obviously, around the adequacy and if the images are optimal. In fact, obviously we may accept suboptimal projections and imaging if it actually is able to answer the clinical question that's provided and enable diagnosis and ultimately management of a patient. And so that's, I guess, really probably something to take away as a strength that, when we're starting with image interpretation, if you're not able to determine technical adequacy, you can't really proceed from that perspective. So looking at a chest x-ray, if you can't identify rotation, you can't identify if adequate inspiration has occurred, for example, then you are open to lots of potential error in interpretation because your inadequacy to determine, that if, say, mediastinal shift is actually due to positional rotation and is not due to a pathology at all. So technical adequacy and assessing that and being confident in that is really critical before we can progress to interpreting and then, I guess, analysing any pathology that might be present within an image.
I think just to add a little bit to that is actually, we're talking today about not just seeing and saying things, but actually documenting it. So if you're undertaking an examination and there are limitations in that examination which affect the adequacy of that examination, it's worth documenting that, because when it is the radiologist or certainly in the UK reporting radiographer who is interpreting that, it's useful for them to understand the limitations or the restrictions you had at the time of actual image acquisition. So I think that's an important thing, again, to sort of reiterate this idea of documenting what we're doing.
So here's one example, which is the UK example. I've actually been away from the UK for quite some time now, so there are lots of different versions of this. I'm sure actually each probably country may have maybe their own versions. There's a 10-point checklist, which is a UK example, which if we look down this list, so it obviously goes through various things. Probably the top one is probably a really critical one in this space. Particularly, obviously, for somebody that's looking at the images later, we have the joy of obviously hopefully having our patient there and actually will have checked their demographics with them directly. But pathology is way down on the bottom of this particular kind of checklist, so that it can reiterate the fact that adequacy is the first stage of that. Obviously, correctly identifying your patient, the anatomical side in particular, because obviously we'll be aware of obviously lots of horror stories in this space where inappropriate markers are put through or interventions occur, for example, for a flipped chest X-ray. So that is a very kind of critical kind of component that we have anyway as a duty of care as a radiographer, but that we're starting off with this inadequacy kind of component or adequacy kind of component first, and before we then progressing on to really looking at is it normal or abnormal, and can we demonstrate the pathology that might be present on the patient. Images, that is.
To jump in at the end, the final point is actually that it's once you've assessed the image, the final bit is actually, do I need to do something? Is there something on this checklist, on this image that I need to act upon? So just because I've checked it for image adequacy, actually part of our role should be, is there something I need to act upon? So I'm just going to give you a very quick example of how this might apply. Okay, so the effective positioning, for example. So assessing whether the positioning, the way we've positioned our patient is in accordance with the expectations we want to see on if you like, on a perfect image. So we've got a lateral elbow here. One on the left is close to perfect as we're likely to get, and the one on the right is slightly off lateral. And obviously in a lateral elbow, we're looking to superimpose the capitulum and the trochlea, which we have on the left. But the one on the right, we can see there's obviously a lack of superimposition between the two. So in terms of image interpretation, one of the things we review and assess on a lateral elbow when we're looking for pathology, particular things like supracondylar fractures, is something called the anterior humeral line. And the anterior humeral line, which is outlined in blue here, if you draw a line along the anterior humerus, it should bisect between the anterior and the middle third of the capitulum, which it does on the left, and that's normal. Whereas the one on the right, you can see that actually that line bisects more posteriorly, so we're more towards the middle to posterior third. So that might imply that actually there's a fracture in the distal humerus, which is actually causing the capitulum and trochlea distal humerus to move. It's not. It's just that it's inadequately positioned. So by having inadequate position, it affects our ability to use the relative lines, signs, measurements, etc. we might actually use to make a diagnosis. Okay, so Jonathan's kind of already posed this question once. Where do we start when we're looking at an image? I mean, we've said, well, actually, the first thing we're going to do is assess technical adequacy. But we're now assuming that we've done that, we've reviewed our image in terms of technical adequacy. Now we are thinking about actually looking to spot abnormalities and make an interpretation. When you're presented with an image such as this, and you've got a lot of things going on, where do we actually start? What is the starting point? Do our eyes just randomly move around the image and pick things up as they go, or do we actually need to have a much more methodical method to use? So, piece of advice, whenever you've got an image, okay, bring your image up, stop, take a break, take a pause, go through the technical adequacy, and then pause again before you actually start looking to see if there's anything there. Often pathologies will jump out and they'll be very, very obvious. And almost what we have to do is just take that pause, ignore it, and then move on and look at that image in a methodical, systematic way.
So looking through a systematic approach, building on what James was talking about there, if you actually ask a radiologist to have a consultant radiologist and talk through, say, a chest image interpretation and ask them how do they look at a chest X-ray, they actually probably not using a system anymore because it is happening automatic kind of process, and that's built up over a period of time. But as a novice practitioner or somebody that needs to sort of develop the image interpretation skills, having this systematic approach which sort of takes you through in a methodical kind of way to really holistically look at the entirety of the image and perhaps look at things which are perhaps not even part of the clinical question or the assessment. So we all will be quite well aware of seeing referrals where perhaps, say, the clinician or the person that's referred the person has particularly assessed the person very well, but it may be quite challenging due to referred pain, how the patient presents, or just exceptionally busy. In, say, for example, in the emergency department, that actually a thorough clinical examination can be challenging. And so therefore the request, the clinical question on the request card actually is a mismatch to really what's inside the patient. So yes, we need to be looking at that clinical question that comes through, but actually we need to be looking holistically at the image. We also have incidental findings, for example, that maybe malignancy or something else like that, which is also would be a significant finding to actually flag. So the fact that we need to have a search strategy enables us to sort of perhaps not ignore, but not to necessarily focus on and hone in on those sort of salient features that James was talking about. I often put a chest x-rays up for student radiographers that we have in the university setting with a clavicle fracture or something like that. And all the students will see the clavicle fracture straight off with this big comminuted displaced clavicle fracture. However, there might be a widened superior mediastinum present on the image actually, which is the life-threatening component. And obviously that needs to be developed with a search strategy to be able to look at that image holistically and see the actual critical, perhaps more subtle feature that might be present within there. Another key thing that ties in with that then is actually satisfaction of search. So therefore, we can have multiple fractures or multiple abnormalities present with an image or synchronous lesions. So that actually looking and having to look for those things. Like saying again, we look at a chest X-ray, we have the humerus cell present on there, and primary bone tumours and metastases are very common in the proximal humerus in there. So we don't look at those areas, we won't see those abnormalities that might be present there. We also have to be aware actually of our errors that our eyes have. We have a huge input into when we're looking at all the time, whether we're walking around the world looking at people. So we make, I guess, errors when we see people in the crowd and think we spotted somebody we know, and then you kind of go to wave and then embarrass yourself because you have to kind of go, that wasn't the person that I thought it was, but walking around in a busy crowd. We do the similar thing with images, and just the image to the left we have here of a Woolworths couple of scones, which you have, or scones, we can probably debate the pronunciation of that for a while, that are present in there. The back scone on there, if I look at that, I think it could look a bit like a corgi. And this is a perceptual error called pareidolia, where we actually see faces and things. So if you think of, the lateral oblique, as well, the oblique lumbar spines, we actually, we look for Scotty dogs to look for the pars articularis defect that's present in there. We have the elephant's trunks for the zygomatic arches on the facial bones. So we actually use that to our benefit by looking at shapes and looking at, animals and faces. But actually we can see things by error. So we see a half a circle and our brain draws in the rest of the circle, and we think we found a lesion when actually it is just composite shadows that are superimposed on top of each other. There's no circular anatomy or pathology that's present. So we also have to learn over time perceptual errors so that we actually don't make image interpretation errors too. So search strategy, here's just a good example of satisfaction of search. So there's obviously many ways of looking at a calcaneal fracture. We've got a comminuted calcaneal fracture, which is salient. It really draws your eye and attention into that area. And when we take a lateral angle anyway all the time, that we are supposed to include the base of fifth metatarsal on there. We teach that and we learn that. But obviously, do we check that base of fifth metatarsal when we're looking at that kind of anatomical area? And so actually there's more than one fracture present in this particular case. So satisfaction of search is king for all images. So if we were looking at a musculoskeletal case, there's an example which you can see published by James and Boyum, which is looking at musculoskeletal cases which can be applied to maybe a finger, to a pelvis, or to an ankle, which is basically a way of looking holistically at the different portions of the musculoskeletal system and really forcing you to sort of spend time. So example, soft tissue signs are something that can be kind of missed in this musculoskeletal kind of area potentially. We often focus on the bones and joints a bit more, so it's sort of focusing the interpreter to spend time looking. For other anatomical areas, then we might need to adjust our search strategy. So this is just one example for the A to J approach for the chest X-ray. There are many kind of image interpretation search strategies for the chest and the abdomen. So I guess perhaps go look at some literature, type it into a search engine, and perhaps find one that works for you, because it's quite critical to sort of break down the soft tissue a little bit more. The mediastinum has multiple kind of components to it, the hilum, and looking at the abdomen, for example. So again, it's this idea of holistically searching and looking at the entirety of the image and the periphery as well, and not just focusing in on one little bit. Worth a second look. I've just put this from my own experiences from reporting from chest X-ray perspectives. We make error. And I think it's probably a bit of an elephant to some extent in the room that radiologists make error, and actually they strive for a 95% accuracy. And that might be higher, might be lower, depending on the individual. So actually that's quite a lot of potential error. Some of that is maybe around the context and the information that have been provided, and that can get corrected later on. To err is human to some extent, and what we need to do is kind of learn from that. So if you've missed something, you'll make an error, and therefore learning from image interpretation, you will actually look at these areas more kind of carefully, these kind of review areas where you've made error previously. So if you actually have a look at this particular image and just check this out, can anybody see any abnormality quickly on there? And if we move over to the right shoulder, and I'm sure James will move the cursor over, and so there, we've got a comminuted and dislocated fracture which is present, which is pretty obvious once you've seen it. But obviously it comes back into, why was the patient x-rayed? And, if we're not doing a systematic search strategy, that may go unattended to and missed for a period of time. And we get good at looking at the things on the periphery because we're used to looking at a lot of x-rays.
Okay, so one of the key things from my perspective, and certainly my students get sick of me using this quote whenever I teach image interpretation to my students, whenever I teach anatomy to my students, and that's from undergraduate students to postgraduate reporting radiographers, but also teaching to other health professions as well. I always bring it back to having a really good understanding what is normal makes the whole process so much easier. So how do you know that something is abnormal if you don't know what normal is? How do you know if it's abnormal if you don't know what it's supposed to look like in the first place? Go on, Jonathan.
I was going to add to that, James, as well, is that if you look at any of the research looking at accuracy for radiographer commenting, then all the false positives are often related to normal variants and developmental anatomy. And so that's where our error typically is, and it's for hands, wrists, and it's the distal limbs. So that really reinforces that, we do need to look at that. And it's a known kind of common problem across anybody that does image interpretation as a beginning.
Absolutely. And the evidence tells us that actually we're better at spotting abnormalities than we are actually saying something is normal. So particularly for novice interpreters, we tend to find that people are overcalling things, as Jonathan says. We're more confident to spot something than we are to actually say, no, I think it's normal. And that's why it's really important for us to understand what we mean by normal in terms of things like age-related changes, the normal variants, how technique and technical factors influence our what we see, the coincidental pathology, things we're not expecting to finding. Okay, so just to bear that in mind, we need to sort of build our confidence in actually and building up what we call a framework of reference, which means we almost have a mental library to know what normal looks like so that we can apply that whenever we're looking at an image. So to kind of give you a good example of this, and this is an area, it's a relatively common overcall where people flag up abnormalities, is the proximal humerus in the paediatric. To recognise that we see this lucent line running through here, which is the physis or the growth plate. But to remember that the physis doesn't run horizontally through the humerus, it kind of takes on a bit of a curved arch within it. So for that reason, you don't normally just see the one line in the proximal humerus. You normally see one which is the anterior or the front edge, and one which is the posterior edge. Okay, so quite commonly people come to these images and think, oh, well, that must be the physis, so this second line must be a fracture, and it's not. It's just relating to the normal anatomy and the technical factors as to how we produce that image. So to give you another example, exactly the same, okay, but this time we've got a person who's obviously relatively lordotic when the image has been taken. So that anterior and posterior edge of the physis are now separated. So again, people's perception is that one must be a fracture and one must be the physeal plate, and it's not. They're both part of the same thing.
I think the alignment as well, James, you can probably comment on that, is one of the, if you look at that ABCS search strategy, helps you, because obviously if your epiphysis and your metaphysis are in alignment, then if you had a fracture that went all the way through there would typically be some displacement present, within there. The fact there is alignment between the epiphysis and metaphysis reinforces that it's normal developmental anatomy as well.
Absolutely. But then going back to something we talked about earlier on, how many people spotted a distal clavicle fracture? So satisfaction of search. Our focus is on what becomes more obvious, and we tend to forget everything else.
And so just to build on a little bit more, which works perhaps particularly for the chest and abdomen and some of the areas if we go outside of kind of planar image interpretation as well, when we get to more complex anatomy, that it isn't just about the anatomy itself, it's also about anatomical relationships. We, I guess, gain and lose silhouettes within the chest, for a good example, but also the abdomen, but even some of the anatomical areas, for example, the elbow, we lose a silhouette when we have obliteration of the fat pads, for example, when we've got fractures where the capsule is ruptured in that area. So a good example is mediastinal borders. There's so many different lines that we need to be checking. So just on the middle kind of image, we've got an image of the right lung, which is on the left side there, which is split into the three lobes. And we can't normally see the greater fissure. We sometimes see the horizontal fissure. It's perpendicular to, I guess, our imaginary sort of central ray that's there. And these strictures can be displaced, obviously, depending on what pathology is sort of happening. But actually, we may lose have obliteration or lose the border of the right heart border. And if that was lost, then that's indicating that actually the pathology would be in the right middle lobe. So actually knowledge of anatomy, but particularly relational anatomy knowledge, helps you actually understand some of the pathologies in some of these more kind of complex kind of areas. Also, just on that same diagram, we've got a lingular lobe, which is like a tongue-like lobe, which sits next to the left heart border. And a zygous lobe, which is another kind of reasonably common kind of variance in the top of the right lung there as well. So as we progress to more kind of complex area, then it does require us perhaps to go back and do some revisiting of maybe some normal variants and things in these kind of spaces and sort of slowly build on a scaffold as we move further through. And the chest is a more challenging area to do image interpretation. So this is just to sort of build on maybe those kind of concepts a little bit. There's a very simple kind of idea that we can have in the chest, kind of space-neutral pathologies that don't really take up space, space-occupying and space-creating kind of pathologies. And these are two very similar-looking kind of things from a first quick look. So the right hemithorax referred to these patients with completely soft tissue, homogeneous opacification occurring from there. There's no bronchovascular markings present whatsoever. And there is some rotation for the image on the left, and not so much rotation for the right. So that's something to bear in mind. There is some rotation of the patient to the right on that left image, but it's minimal. It's not going to be causing the amount of displacement that's present within there. So that condition that's on the left image has a very space-creating pathology. So that is pulling sinus contents of the trachea and the carina and the left and right main bronchus towards it. If we look on the other side, on the other image on the right side, then, for example, we can see the calcification, the arch of the aorta. We can see the left main bronchus and the cardiac silhouette is actually almost touching the lateral chest wall. So that is a space-occupying condition in that right hemithorax. So this is basically a total pleural effusion on that right image. So massive effusion, which actually can become a tension effusion, similar to a tension pneumothorax, and can cause tamponade and can be quite significant. So that can be a medical emergency, just the same as kind of a tension pneumothorax. And we've got a total collapse on the other image, which could be anything from a pneumectomy, where the lung has been removed, through to maybe perhaps some kind of obstructing kind of tumour or something else like that. But then from a quick look, and a lot of people were potentially, that's just a pleural effusion, but actually it's very different. So having knowledge of one, again, coming back to that, is the patient rotated, the technical adequacy that's present there, to then actually then be able to, even a simple thing is space creating, space occupying, a space neutral kind of pathology, actually helps you to sort of differentiate between kind of key common pathologies that we might see in the clinical setting.
Okay, so one other thing to sort of think about here is, and what's key in this is, we work as part of a team. That we work not as individuals for the majority of the time. And I think one thing to remember with image interpretation is that you don't necessarily have sole responsibility for making those decisions. Ultimately, you are not the one who will be providing the final definitive report. What we are talking about here is you providing an invaluable opinion to ensure that patients receive the appropriate care in a timely manner. But that doesn't mean that you cannot use other sources of information and support to help you in your own interpretations, but also writing interpretations in terms of comments. So we need to also remember, as well as looking at images, we do have a lot of other resources and information available to us. Okay, so a couple of sort of, again, key phrases that I typically use in my teaching is the most valuable image is a previous one. And that, I think, particularly in the chest x-ray, if you've got an old image or a previous image to compare to, that it really, really helps to decide whether what you're looking at is acute and significant, or whether it's potentially been there for quite a while, it's a normal variant, etc. One view, too few. Okay, so images are about perception, and we've got an example here where if you're only looking at things from one angle, it can look very, very, very different as if you were looking at another one. So obviously we're aware that by standard, certainly in the skeletal system, we take two projections at 90 degrees to each other to ensure that we're looking at things from a different viewpoint. What about the information that's provided not in the image? So thinking about the patient's presentation, their clinical history. Have we got a mechanism of injury? So what forces were applied to the bone or the joint at the time of the injury? What are the likely injuries we're going to see a result? What are the patient's symptoms? If we've got an appearance on the chest x-ray and the patient is presenting, say, with a cough, they're producing a lot of green sputum, they've got a pyrexia, they've got a fever, what's that most likely to be? But we have to take that and we have to be careful about that, because we do sometimes see and come across weird and wonderful things that don't fit the normal patterns. Okay, so use that information, and one of my tips is to look at an image almost like without bias. Without that clinical information, review it almost as if you had no other information, then go back to it looking about what clinical history have I got, what information have I got, and you can then provide a bit more of a focused interpretation on the areas where you're more likely to see pathology. And don't forget that you can talk to people. You know, if you think you see something, you're not sure, ask your colleagues. Speak to a radiologist. I've seen this. I'm not sure what it is. I'm not sure if it's significant. Yeah, and all of this is it's a team effort. It's not about we people working as individuals. So a good example of the one view is two view. We've got an ankle projections here. For all intents and purposes, that fracture is completely invisible on the mortise projection. However, it's a lot more clear on the lateral. So that's why it gives us a good example about why we have to use multiple projections, excuse me, but also about making sure that we're looking at each individual image as separate things. So the kind of the final thing we're going to talk about before we sum up is about, okay, well, we recognise that we have a role and responsibility in terms of actually looking for and communicating findings. We've talked a little bit about some of the key principles about how we actually do it. How do we then go about actually communicating that to colleagues, to other health professionals? So essentially, certainly in terms of commenting, or really in terms of any image interpretation, what the people you're speaking to want to know is whether you think the image is normal, whether you think it's abnormal, or actually whether you're unsure. Even if you're not sure whether something is present or significant or not, it's still probably better to identify that you're unsure than simply just to ignore it, or say I don't know, and almost take the easy route out. When we are communicating, we want to use a language that is universal and understandable. We want to make sure that the people we are communicating to understand what we're saying. So we don't want to be using radiography jargon or terminology that, say, an ED clinician might not understand. We try and avoid using eponyms, things like Colley's fracture or Jones fracture or things like that, because if the person you're saying that to doesn't understand what that is, then it makes no sense. So you're better off describing what you see than actually using names like that. So, for example, a Colley's fracture, we might say there's a distal radius fracture with posterior displacement. Okay, so that describes it, and it's much more universal. The aim of a comment is not necessarily to make a diagnosis. As we've said before, this is an interim interpretation rather than a final formal report. So if you don't know what it is you're looking at, that's absolutely fine. If you see the previous examples, Jonathan talked through the big pacifications in the hemithorax. If you don't know what it is, you don't need to make that diagnosis. Just describe there's a pacification throughout the right hemithorax. There is deviation of the trachea towards their pacification. That's sufficient. It should answer the clinical question. Okay, so if you've got a clinical question from a referrer, why is the x-ray being undertaken? Why is the patient being referred? So your communication should aim to try and answer that clinical question. Is there a fracture? I can see no fracture. Or yes, there is. This is the fracture that I've seen. And again, remember, this is not about you making a final diagnosis. Yes, we have a responsibility to act on things when we see them, and we have a duty to communicate them. But we are not alone with this, and that this process does not replace the need for a formal clinical report. Another point. So one example. So one of the things that I've found in students and radiographers struggling to write or communicate findings is that they actually struggle to articulate what it is they're trying to say. So it's useful to almost try and come up with a little bit of a recipe for abnormalities and how you actually say what you see. So one example is called the what, where, how method. And it's particularly useful for skeletal trauma. And what it does is it identifies three key features of trauma, fractures, dislocations in particular, which tell you what is the abnormality, where is the abnormality, and how bad is it? How is it displaced? So, for example, we could say the abnormality is a fracture. It's a transverse fracture, or it's a dislocation. Where is it? Okay, which bone is it? Is it in the radius? Well, where in the bone? The distal radius, the radial metaphysis. Okay, how is it displaced? Which way is it moved? Anterior, posterior, radial, ulnar. And how much is it undisplaced? Is it a mild degree of displacement? Is it a significant degree? And essentially all you're doing then is making a list of what you see. And if we've got more than one abnormality, we just do it multiple times. So, for example, we have got a relatively obvious fracture here, and some of you might well be saying, oh yeah, that's a boxer's fracture. But as we've said already, we'd want to try and move away from using eponyms, because if you say to someone, oh, that's a boxer's fracture, they might not necessarily know what you mean. Whereas if I was to say, right, what is it? Well, this is an oblique fracture. Where is it? It's in the neck of the little finger metacarpal. And how is it displaced? Well, it's the head of the metacarpal is displaced or angulated volarly or anteriorly. So if we put that together, what we've got is an oblique fracture, the neck of the little finger metacarpal with anterior or volar angulation. And that's it.
And right.
And right, yes, sorry, well,
yeah.
Thank you.
Anatomical side in there.
Yeah, thank you. You got that one in there. So we've got another one. So this is obviously a dislocation, okay, of the left little finger. I shall get in there that first. So what have we got? It is a dislocation. Where is it? We could either describe it as being of the middle phalanx or at the proximal interphalangeal joint. And how is it displaced? Well, it's displaced posteriorly, but also ulnarly as well, so towards the ulnar side of the hand. So we've put that through together again, and we have a dislocation of the left proximal interphalangeal joint of the little finger with posterior and ulnar displacement, and that's it.
I think this is a good example for thinking about the satisfaction of search, because if you've got a traumatic dislocation, then obviously you've got ligaments and tendons that get put under force, and so the avulsion fractures are quite common with these. So that's the next phase. Then you see a dislocation and think potential avulsion fracture. So that's that sort of taking it a stage further. Just because we've seen a dislocation doesn't mean that your interpretation search stops there. There could be something else that may be present that might be subtle, which that's that salient feature. But the avulsion fracture could be quite subtle, which there isn't one in this one. But just if you don't look for it, you don't see it per se. So here's just another example. It probably ties back to nicely the coroner's kind of example. So we've got another a pacified left hemithorax. So on that left side upper middle zone, we have got no bronchovascular markings. We can't see the left heart border. We can't see descending aortic arch or anything like that. We have the left main bronchus and some of the bronchial tree that's there. We can't see the hilum or anything like that. The person is rotated to the left. But does that degree of rotation cause the mediastinum to be displaced over there? Well, it doesn't, does it, when we think about, kind of appearances that we're taking there. So we have obliteration of the hemidiaphragm as well. So there's nothing really kind of borders present on that particular case. This is a mobile X-ray on somebody that is obviously quite acutely ill. They're being monitored, got ECG electrodes and leads present in there, which are artifacting quite nicely all over the chest X-ray. So we could have moved those perhaps out of the way of the lung field. But then we've got an endotracheal tube, which is present on the individual, which is seen because actually they've got a lot of flexion of the chin as well. So we can see actually pretty much the entire length of it, that really opaque line that's present in there with the break that shows you where the tip of that is. And so that endotracheal tube is entering into the right main bronchus. So with it being steeper, wider, and it's usually typically where you get a foreign body, for example, would go into that space preferentially over the left. So what's really occurring just in that case is that we've got an advanced ET tube which is present there, which is aerating the right lung, and it's caused the complete collapse of that left lung, so that needs to be retracted, and that is a potentially life-threatening finding that's there. So it's not just see something, say something, but it's actually physically be telling somebody immediately now, because that needs to be managed. We went back in time with older ventilators, actually then that could cause some ventilation kind of damage. They're a lot cleverer now. They know and can measure things and pressures and stuff, so they won't cause barotrauma, but perhaps in times gone by, if you've got older equipment, that potentially could occur. So that is a life-threatening thing. So if we're talking about this see something, say something, this is something that, we need to be literally flagging this now as an absolute emergency type setting, because they just need to pull back, and then there will be reinflation of that left lung field pretty much kind of straight away. And obviously ET tubes are quite critical for positioning for life. Yeah, airways going in, breathing and circulation. So it kind of falls in the ABC of ATLS. So where next? So there's a whole range of things that you potentially could do in this space. If you're wanting to develop your image interpretation skills, actually there's a huge array of resources that are available. I'm not going to flag any specific resources online, but obviously, there are plenty of actually really high quality image interpretation kind of websites and available now, which are free. Obviously, you can subscribe to and pay for some of these things. If you want to develop your image interpretation skills, I guess, a little bit more formally, then there is actually postgraduate education, particularly in this space, also short courses that are offered in the various kind of countries, which might be online or face-to-face too. So I think that's something to kind of consider in that particular space. I think from James alluded to earlier that also that, reaching out to people that have image interpretation skills and developing these perhaps in those sort of settings. Radiologists, we need to work better, more collaboratively within that space. Certainly within an advanced practice kind of space, we get to collaborate with radiologists and perhaps break down some of those barriers in that space. I think there'll be more that we work with them to show that this is a collaborative process to benefit patients, reduce error, and make imaging or healthcare more safe by picking things up early. Particular as a great example, the AT tube that was to advance that particular chest X-ray. There's quite a bit we could be doing that doesn't necessarily require you to enroll in a master's. But then again, that could be something you would want to do, and you certainly could do a master's in image interpretation in this sort of space. And if you want to add to that, James.
No, I think the other thing I perhaps would just also say is actually when we go back to basics as well and think about how your existing education, your existing training, so things like we've talked about already about going back to your anatomy, your physiology, your understanding about what essentially the images we're looking at are people's anatomy, and the better you understand that, the better you understand what you're looking at. So you can kind of, as a starting point, go back to those textbooks, go back to the technique as well. And as we've talked about, the effect of our technique, the effect of exposure factors, and what that has on what we see. So in many ways, you've got those skills already, you've got that knowledge already, but you almost go back to the start and think, well, how would this influence my ability to actually interpret what I say and understand what I see? And have a think when you're looking at images. I always say to students, well, and health professionals, just look at images. That's probably one of the best ways to learn. It's actually spend time to actually look, rather than just say, yeah, okay, it's technically adequate, off it goes. Right, well, what about the next step? Is it normal? What can I see? Is there anything right? And if it's normal, fine. Add it to the image bank in your head, in your brain, so that you've got more in that image bank in your brain, that framework of reference to use in the next case. So practice. I think that's probably one of my biggest tips.
And we might make error, and that you have to accept that we will make error. And if you're not making error, you're not doing enough. But you need to learn from the error. That's the key, and perhaps adapt your approach and your technique. And that's, if we learn from it, then that's really good.
So the final thing is really just sort of reinforce the message of this. This is based around patient safety. And what we're certainly not saying that this is going to be universal practice globally. As we've said, it's relatively common practice as commenting in the UK. There's a big push and drive for it in Australia and other places. Okay, but one of the key things is, as one of the example that Jonathan gave earlier on about if someone was having a cardiac arrest in your department, you wouldn't just walk on by. So would it be the same if you were looking at an image? If you see something and you think it's significant, then you need to say something to a clinician, a radiologist, the referring clinician. But as well as that, you need to actually act upon it. You need to actually do something about it. Okay, document it, write things down. All right. If you haven't documented it, if you haven't done anything about it, then you haven't done anything.
Yeah, I think that document trail is really critical. If we think that we're an allied healthcare professional, pretty much any other allied healthcare professional is documenting their clinical decisions, their interpretations, or whatever that will be of whatever type of test and assessment actually in patient notes. We probably, as radiologists and radiological technologists, need to own that space and actually become an allied healthcare professional and start documenting, communicating our things more strongly. And I think the fact that it's an act on it, that depending on your context and where you're based, you might not have a radiologist, you might not be in a hospital setting. Obviously, we might have to, enable admission. We might have to, immobilize an individual depending on the sort of setting. So obviously, lots of people walking wounded that can come in with quite significant findings that may be present on the images. So, it's not just literally see it, say it. Is that, there's some action that may be required. And what that looks like is very context specific. But we are duty bound, really. I feel personally, I'm sure James does as well, that, that's critical. And I think the general public would expect us to actually be acting on the knowledge and skills that we have.
Okay, so that's the end of our webinar, our presentation. Just leaves us to sort of thank you all for listening. Thank you to the International Society of Radiographers and Radiological Technologists for the invitation, the opportunity to speak to you today. And we're happy to take any questions now.
Thank you to James and Jonathan. What a fantastic presentation that was, and really kind of hones in on what's really important within our profession, I think, and how we can help to improve patient safety overall. Thank you both for turning your cameras on. There's been a fair bit of chatter while we've been watching this presentation amongst the audience. A lot of questions kind of were coming in a little bit, and I'd kind of just like to dispel a bit of a not a myth, but I guess an issue here is that a lot of questions were coming in about, are we expected to be reporting, and are we expected to be, doing the job of a radiologist and that? And I'm just kind of just putting that out there and just saying, definitely not. That's not what this is about. This is just about making sure that we're just communicating the findings themselves. Look, we don't have a lot of time for questions. I do want to say though that just before the webinar began, myself and the Isrrt board of directors were just having a bit of a WhatsApp kind of conversation, and one of them, our president Napapong Pongnapang, actually said in some countries doing this would actually be considered illegal. To which the reply was, if it should be illegal to not do this more than anything else, I think. Just going through just a couple of questions. The first one was, where do you write the accidental or abnormal findings? Are you suggesting that we put it into packs or into a clinical file or something else? Oh, sorry, James, you just got your microphone muted.
Apologies. Yeah, I think it depends a little bit on how you're working now. If we go back sort of a number of years when we were still using film, as in some places we still are, then it was literally a case of writing it down on a comment form, a pro forma that kind of went into the X-ray packet and followed the patient around, and in many places, even though we've gone to packs, that is still the way it works. It's a paper form that follows the patient. In many ways, and we found this in the UK, one of the reasons why commenting hasn't perhaps taken off as much as it perhaps could have done is that the technology doesn't necessarily always allow it. That actually, and this is a conversation we've had with vendors here, in that actually the pack systems don't necessarily allow us to attach a comment onto the image or anything like that. And so what people are having to do is almost do workarounds and use things like paper-based copies and things like that. So I think it really depends on how you work and what works best for your department and the way you do things, because certainly as we've found that the technology actually almost can be a hindrance to actually doing this practice.
So are we kind of advocating then for such a practice to be a department-wide initiative, or are we talking about something that individuals should be looking at?
Well, sorry, go on, Jonathan. I think one of the things that perhaps we maybe didn't allude to in the presentation is all of these practices, they should be backed up and based upon a quality mechanism or governance behind the practice. So this is not necessarily something that we as individuals should just go and start doing. There's got to be a degree of quality behind it. So things like scopes of practice, schemes of work, what is the policy, what is the protocol, what can we comment on, what can't we comment on? So there needs to be a degree of work behind the scenes in terms of actually setting up these practices rather than radiographers or radiological technologists go and doing it, almost ad hoc.
Yeah.
I think go back to your question regarding the how do you communicate it, and I think that's been a big struggle here in the Australian setting, and actually probably some of the differences where actually they're using the technology and communicating often in a digital format, and the individual sites and I guess areas they're doing it have gone down that route far more. And I think that the scope is quite clear. So the UK is interesting that it generally focuses on emergency department referrals, whereas actually the capability for Australia is actually far broader and actually doesn't even necessarily focus on just general radiography. And yet that hasn't progressed yet in that stage. So I think it's in this whole holistic buy-in, and obviously it is also that collaborative component with radiologists. It's not a replacement of radiology. This is a preliminary guess based on the fact there could be a delay in reporting process to actually guide urgent management of conditions that actually make a benefit for patients.
And what in those situations, Jonathan, what happens if you don't get much of a buy-in from your radiologist? Because I have heard that happen.
And that's one of the challenges. And to be fair, even in the UK, we have, I guess, tinted rosy glasses that everything is perfect in the UK from a radiography reporting perspective. We have these amazing relationships, but we do have a very good relationship with radiology. However, there still is even pushback in a UK setting to some extent with radiographer commenting. And obviously, we look more globally. There certainly is a big hierarchical push from medicine sometimes away. We've seen a very strong negative commentary from Randstad, for example, with an Australian New Zealand kind of setting. So it's something that actually has to break down barriers and culture. But I think the message really coming through from yourselves in particular, for example, is a great example that, it's a collaborative process that actually radiographers clearly do have. It's proven with research, we have the skill set and knowledge in this space we can develop in that space, whether that's for commenting or even going down the formal reporting route, and that we can make a difference that actually increases patient outcome. And so, I think we have to keep building on that and trying to break down some of those barriers and work more collaboratively with radiologists over time. Obviously, some of the people listening perhaps may not have radiologists. So, I live in a country where we have radiologists and they do get reporting. Some people don't have access to that. And they may actually be the only thing between them and the referrer to actually provide some kind of commenting in that space. So obviously, globally, there's a huge amount of variation in context and practice.
Yeah, if I can, I'd just like to add a few things onto that. And I think, again, first and foremost, what we're saying, this is not aiming to replace, and we're not saying this is formal reporting, because yes, there are legal restrictions to that. This is definitely not what we're talking about. This is about radiographers using the skill sets to act upon in circumstances where essentially there are patient safety risks at play. And, one of the reasons, again, why it's not necessarily taken off completely in the UK is because we've got circumstances actually where we've got 24/7 hot reporting, where you've got a radiologist actually there reporting it out there. And in that circumstance, we don't necessarily need a commenting system because we've got that formal report there and then. But in settings like rural settings, and we haven't got radiologist cover, or that report is going to take several weeks to come back, it's that kind of setting where you kind of want that system whereby a radiographer can offer an opinion in the acute setting that will, in the interim before that report is actually attained. But as Jonathan says, that collaboration, this is, not just us going alone. We need that buy-in, we need that support from the radiologists. We all need to recognize again what it is and what it's not. And what we're not doing is wanting or necessarily saying we are going to be providing formal reports. That's not what it's about.
I think if I'd probably use a specific example would be, you're working in the middle of the night, taking a chest X-ray on the ward, for example, and you don't have a radiologist on site. You see a tension pneumothorax. That's something that needs to be acted upon immediately because patient safety, of course, is paramount as far as that's concerned.
Yeah.
And that's exactly what this is all about. Look, I'm just going to go through maybe one or two more questions before we finish up. I have noted that Jonathan has strategically placed a clock behind him, which is showing 11:10 p.m. in Australia at the moment. So thank you for that, Jonathan, for keeping me up to date with that. One question that came through was a little bit left field is how can AI detection systems, or how would they basically impact our daily practice as far as this is concerned?
We don't know. This is interesting. And we're both doing research in this kind of space. And I think that's the unknown. I think one of the things we probably can say is that if we don't embrace this space, then AI can quite easily replace us in this space. So there probably is a big argument for us to embrace this technology. Obviously, AI has a huge potential to increase accuracy. However, the safeguard rails need to have a human component with it. So obviously, reporting radiographers and radiologists are already using AI to supplement and help increase their accuracy. So that we should be the same, that we should be utilizing it the same if it's available too. But it's not really being used in preliminary commenting as of yet, is it, James? So.
No, and I think that it's sort of commonly, we're talking about AIs. It should not be seen as a competitor or a threat. It should be used as something that will support our practices and essentially give us extra confidence. So again, one of the biggest barriers as to why radiographers don't necessarily want to engage, in commenting is a fear of getting it wrong. A fear of or a lack of confidence in what they're actually saying. And in a way, the AI hopefully will provide that little bit of extra confidence to sort of back up what we're saying. And it's kind of Jonathan alluded to, we've just put out a scoping review on the role of commenting globally. And our closing gambit was really that AI is coming And unless we actually embrace it and we embrace the opportunities for of all this, we're going to lose it. So we want radiographers to develop their skill sets. We want them to be confident in looking at images and seeing things. But if we don't, then AI potentially will come through, and we're not going to be able to do anything about it.
Yeah, yeah, I think I agree with that. There are a lot of questions, and I do apologize to those that have put questions up that we're not going to be able to get to. I do want to finish with this question because I think this one actually is a really important one to help to understand. And that is around a threshold of when you do and when you don't necessarily need to comment. Outside of the medically critical findings, such as a misplaced NG tube, that's I would kind of consider that probably a critical one. But what about radiographer commenting, as you were talking about with the distal clavicle fracture, for example, that's not necessarily something that's going to need urgent attention straight away compared to something like a misplaced NG tube. And where's the threshold that we really need to kind of focus on? Because I think is this an all or none approach? Is this something that we should be kind of taking baby steps towards or something like that?
I think to a certain extent, it goes back a little bit to what I was saying a little while ago, that what we want to happen is not that people are just going alone and doing their own thing. We want this to be based upon, a governance program which outlines things like, well, what is covered and what's not covered. So typically within the UK, the commenting system classically is all ED trauma or acute from the ED. And the protocol will identify that essentially these are the groups that you can comment on. These are the types of pathologies you can comment on, and those that fall outside of that is typically what we would not cover. So for me, I think it goes back to this, that if we are going to be doing this, we should be doing this collaborative together to identify, for example, what we should be commenting on and what we should not be commenting on, and not leaving this little bit of ambiguity and think, well, is that significant? Is that not significant? Should I comment on it? Should I not? I suppose the bottom line could be, if you're not sure, you're better off putting your hand up than just ignoring it and saying, oh, it'll be fine.
I'd probably add to that as well and say it's not necessarily the scope of practice of a radiographer to determine whether something is urgent or not urgent.
Yeah.
It's just to basically discuss the abnormal finding, whether it is minimal or maximum.
Yeah. And if you're not sure, ask the question. Ask.
Yeah, absolutely. Absolutely. Jonathan, James, thank you both very, very much for joining us today, for providing us with this wonderful insight. Thank you to everyone online for joining and for getting in and registering quickly. We managed to max out our 500 registrations that we have available to us. So for those for future webinars that we're going to run, please make sure that you do register as soon as you see it, because you may miss out on the registration. Thanks again to both of you for joining us. Thanks to everyone online, and have a good day.